Hi, everyone, and thank you for joining us for today's free webinar presented by Aspire Respiratory Products. This webinar may win for Best Title. It is entitled Researching the ICU, where the only constant is chaos. And we are honored to welcome our speaker for today, Dr. Martin Brodsky. Dr. Brodsky serves as section head for speech-language pathology in the head and neck department within the Integrated Surgical Institute at Cleveland Clinic. He is an associate professor at Johns Hopkins, an ASHA fellow, a researcher, and an internationally recognized speaker. We are so grateful that you are here today with us. Thank you, Dr. Brodsky. We will ask from the audience that you kindly hold your questions until the Q&A session at the end. And Dr. Brodsky, I will give you the stage. Thank you.
Thanks so much, Jenny, and thank you to Aspire for allowing me to present this webinar. This is going to be a little bit different than I think most webinars in that I'm going to reveal some of the things that have gone on behind the scenes and some of the things that you'll only hear about in like the dark corners of the ICU or the dark corners of research offices that have gone on during my tenure as a researcher doing all this stuff. To kind of give everybody a little bit of a background, I'm more than 30 years in the field. The last 20 or so have been researching the ICU and primarily at Johns Hopkins University and Johns Hopkins Hospital. So all of the information that I'm presenting on studies today was completed at Johns Hopkins, and I want to give them the shout out to this. I have phenomenal collaborators, an incredible team that I've been working with over these many years, and we're still working on these projects. You're going to be seeing hints of upcoming information that we're going to have. We've only published once on the direct study called PALS, if you're familiar with that. We'll cover that a little bit later. But without further ado, why don't we get going? And I think I've dangled enough carrots in this already. The disclosures here, there's nothing there that I have that's in any conflict with this seminar. And we talked a little bit about critical illness and critical care. So here's the word cloud. And the word cloud is something that the audience responded to. This was their responses typed into their own devices. And as you can see, the words complex, intense, fragile, tenuous, serious, dynamic, acuity all kind of leap off the page at you. But as the title of this presentation suggests, you can see that the word chaos was not, in fact, left off the page. So with that, I want to bring you into a word that actually came from this. So that was the exercise that I went through. This was the one word that the intensivist, who is a staff anesthesiologist, and you'll hear more about him shortly, came up with the word in ICU called hope. The way that intensivists often think about ICU is not all that stuff that we think of that's the pure chaos and the hell that ICU is. It's not the hanging on for dear life and everything, negative and the stark reality that may take place in ICU. Rather, they look at it with terms of hope and hopefulness and the things beyond the critical illness that kind of put people at ease. And I want to start with that because even though this was just over a month ago, in a 30-year career and 20 years doing research in the ICU, the word hope, I'm sad to say, has never really come to my mind with regard to ICU. Now, with that said, as a therapist, the word hope is in my soul, and I suspect many of yours as well. So I want to kind of give that as the background, and maybe we can go forward from here with what I think this word hope is pretty inspiring when we think about healthcare and certainly when we think about ICU. So then we moved into this thing on how we define critical care. The first thing that we need to know is that it is a specialized area of medicine. And believe it or not, it was only 30 plus years ago that it was accepted by the American Medical Association as a specialty. That's right, 32 years ago. Interestingly enough, I suspect most people attending this webinar are probably younger than that. But the others of us who have been around have been actually around longer than critical care as defined as a specialty has. So I want you to put that into perspective. It is focused on the diagnosis and treatment of life-threatening conditions. And I think that kind of goes without saying it's one of those things that comes readily to everyone's mind when we think ICU, people hanging on for dear life trying to get better, or at least move past that in some regard. And then finally, it requires comprehensive and continuous monitoring and support. And you can see those detailed below. So that is what critical care is. That is how it's defined by intensive care medicine. That is the synthesis of the definition from the Society of Critical Care Medicine, and I suspect many societies around the world. This is what critical illness is relative to clinical care. And people, as you can imagine, come into the ICU with a critical illness. So once they have that illness, they're often and most likely admitted to an ICU or waiting for an ICU bed. And then it goes through the rest of this flow diagram in terms of the things that happen when you're in ICU. Coming back a little bit toward the research and the research that I've done, my research actually begins right about here at this arrow. It is very shortly after they get into the ICU. And it's following them effectively, somewhat retrospectively, from the minute they entered the ICU and when they were intubated and through hospital discharge, whatever occurs in the middle there. Now, I want to come down here and talk about discharge from the ICU for just a minute. There are only two ways that we think about discharge from the ICU, and that is you're going to go home to an extended care facility, a rehab facility, somewhere where you're going to continue to get better. You're going to move down the stream of, or the continuum of healthcare, all the way out to outpatient and hopefully be discharged from outpatient having a better quality of life. But the grim reality is the other way you get discharged from the ICU is death. And whether you go to ultimately the morgue to be taken to later arrangements beyond that, or you go to pathology and autopsy to find out a little bit more before you go to your final arrangements, this is a stark reality. And interestingly enough, in ICU, rates of death can spiral depending on what you've seen. And we've all seen COVID at this point. Everything from a bare 30 to 40% on the low end to really high numbers. So anybody working in these areas of the healthcare system, the ICUs very specifically, have to know what they're getting into, and that's the stark reality. Let's separate ourselves. We only work with the living. We're only working with those who we can rehabilitate, and that's where everything is. But the real ICU, believe it or not, whether it's clinical or research, has often been thought of as a dumpster fire. And in fact, in the ASHA Healthcare Summit, the palliative care specialist that we had speaking there actually showed a very similar image, and she agrees that even a palliative care specialist will say that the ICU is a dumpster fire. Now, that didn't go so well in the title, and I stuck with chaos, but I think the two kind of come together, and you understand where I'm going with this. It is unpredictable. It is dynamic. It is everything they can do to keep people from dying or help them along their path toward death. It is on that edge where every single day these professionals are. That's where the research is too. And what you'll see a little bit later in this presentation is how we get to that point and many of the things that kind of interfere with the research along those lines. For right now, I want to back up a little bit and talk to you about the multidisciplinary team and the people that you're going to constantly run into with regard to who you see in the ICU, who you're going to interact with, because nearly every single one of them will have some level of participation in your research. So we can think of the ICU core team as those who effectively spend all day, every day in the ICU. Those are the physicians, those are the advanced practice providers, those are the nurses and the nursing assistants, the respiratory therapists, and depending on where you are, depending on the model that's chosen in that particular facility, you may even get registered dietitians and social workers who are assigned to that unit, who are on that unit all day, every day. Moving on from the team, of course, everything revolves around the patient, which is the reason why I put them in the center. But it's not just the patient, right? It's the patients, it's the caregivers. And if you want to get into the legalese, the regulatory, the things that we deal with on the research side related to the Institutional Review Board, these names are proxies, surrogates, and even custodianship for the people who will actually sign the documents, the people who will sign the consent forms, the people who will often allow you to work with their loved ones or the ones they're taking care of simply because the patient is too sick. They often cannot consent for themselves, so you need somebody to be able to do that for them. And those are the three names that you'll often see in medical records combined with research records. Finally, it is not it actually is quite frequent that you will run into the referred services because so much of what we do as a speech language pathologist revolves around these other specialties. ENT, GI, neurology, and so forth are among the examples. Then you've got the allied health folks, speech pathologists, and other colleagues that we have on the team passing the baton between us for continued care. Occupational therapists and physical therapists are very often on the units. So if you really want to get down to it, there are a lot of people that we're going to be working with in the research realm, and you see where this parallels the clinical as well. We are often working with every single one of these individuals when we're in the ICU. These next few slides have a little bit of a different take on the ways that speech language pathologists and other members of the ICU team interact with the core ICU team. These three folks joined us for the ASHA Healthcare Summit at the beginning of May, and I just want to point them out as having credit to these slides. So Steve Insler is the anesthesiologist that I talked to you about earlier. He is the medical director of the CVICU at Cleveland Clinic. Lindsay Kreischer is the manager in respiratory therapy at Cleveland Clinic on the inpatient service. And Lynn Kokosa is a clinical nurse specialist, also in ICU and very specifically in the medical ICU. So they put together these next several slides, and I just, with their permission, I'm able to show these slides to you. So instead of responding to my question of how does the ICU team interact in a Venn diagram with speech language pathologists and other members of the team, they chose a different route. This wasn't a Venn diagram, and what you'll soon see are the different layers, if you will, on how people interact with each other. This has extreme clinical relevance, but you'll also see in the little crevices the insights that you can get toward the research side as well. And this is why I say it gets a little bit chaotic. We all start with the patient and the family in the center of everything. They are the reason why everybody's there in the first place, right? Okay. From there, you have the ICU providers. that come into the fold, that these are the ones who are sticking around in the ICU, what I referred to as the ICU core team. They're the ones surrounding the patient at all times, right? Actually, we have another level, and that's the rehabilitative and consultants that are providers as well. And you'll notice the speech language pathologists up here in the upper left corner, along with other allied health folks, the dietitians, the ethicists, and so forth. Again, all of us surrounding the patient. And then finally, some folks you may not be thinking of, but have a critical component to both the clinical care and the research side of things. These are the unit coordinators, the supply chain folks, that the ones who stock all of the things that we use. For example, the one-way speaking valves. You've got facilities management, cleaning up and keeping us all safe from infection. Quality and patient experience folks, trying to make things better for everybody, right? Can't do much without the volunteers because we always need more staff than are actually able to join us. Then we've got environmental services. Again, same thing. We're talking about infection. We're talking about cleaning up in the room. Information technology, most of us are using the electronic medical record, right? So that's got to be kept up to date. And now with research, things are integrated into the medical record, such that depending on the system you're in, you'll see flags as to who's actually on a research study when you pull up that chart. And then finally, the preventionists, typically the epidemiology folks, the folks who are looking out to see what's growing where and how we prevent things from growing, right? Okay. Coming back to that whole critical illness thing, we start with the patient and family. And as they move along these peaks and valleys that are in ICU, hopefully working toward more peaks than valleys, they're going to get discharged from the ICU. And the real question is, are they going to recover from their ICU stay and move on to the next lower level of care, or are they going to die? And again, depending on the patient, depending on the time, depending on the condition, all of things are held in the balance, right? This is where our story begins. So let's come back. As I said, I want to hit on a couple of the research articles I did previously because I want you to look behind the scenes in these articles very specifically. Some surprises, if you will, that I found out either during or following the research, during or after the research was published, and things that will kind of be illuminating, if you will, toward these particular articles, but are lessons for all of us. So this particular article, I started out, it was one of my first articles. We took a look on a prospectively acquired set of data. There were 520 patients who came into this study, and they were being followed for what was then called, and I'm dating myself a little bit here, acute lung injury. Right now, following the Berlin definition that came out in the early 2000s, we now call acute lung injury ARDS, or acute respiratory distress syndrome. So, moving forward from here, the real question is what was going on relative to the swallow screens on these patients? 520 patients who came in with what I'll just refer to it as ARDS, and what happened with them. Of the 520, and we'll talk about those in a bit, 178 made it into this study from 13 ICUs in 4 hospitals. It was a multi-site study within the city of Baltimore and around it. These were adults who had respiratory failure. They were orally intubated and never trached. The results ended up that there was a median of 8 days while they had oral intubation, and their lengths of stay were about 12 days in the ICU and a total of 22 days, including those 12 days in the hospital more broadly before discharge. Okay, so these are pretty extensively impaired patients. They stuck around in the ICU for a week and a half, almost 2 weeks, and they were in the hospital for 3 weeks or just over 3 weeks. Pretty impaired patients. Okay. 80% of them, of all of those 13 ICUs, were admitted to a medical ICU. Okay. And here's the flow diagram. 520 patients came in. 45% of them, remember that 40% number I gave you earlier? 45% of them died before they could even get into the study. 284 patients were then followed in the ICU. Another 106 were excluded for various criteria, which led to the 178. Okay, nothing mysterious here. This is a typical flow diagram of any study. This is just the flow diagram for this particular study. Here's where the results are. That 56% will come up in a minute. Here are the practice patterns. 3 hospitals. Remember I said 4 hospitals. The data, if you read the paper, realize the 4 hospitals down to 3 hospitals because the 3rd hospital actually managed the 4th hospital. So effectively, we combined the two. I think there was less than a handful of patients. So of the 61 there were maybe 5 patients that came from the 4th hospital. And frankly, at this point, I'm too distant from the study to let you know whether they were included in the data or we simply excluded them because it wasn't representative of that hospital. Unimportant for our discussion here. What I want to point out is that 44% of the patients actually had some form of assessment with regard to a swallow screen. Now, I want to clarify that either had a clinical swallowing evaluation by a speech-language pathologist, or they had a screening by a nurse, or they had both, but 44% of them, or 79 of them, had that. Let's look a little bit deeper. I'm going to start vertically first. Hospitals 1 and 2 had about a quarter of their patients actually seen. Again, this is any assessment. We'll talk about the ICU and the ward a little bit later. Any assessment, a quarter of them got it. In this other hospital, there was 46% of the patients who actually got something. So this is a stark number that's really different, almost double the difference here, which kind of had me scratching my head saying, what in the world went on? Now, full disclosure, they were just ending this study as I got to Hopkins in 2008. So I was not involved with this study at the front end. They were just finishing up data collection, data cleaning on the back end. And I wasn't the one who asked the questions on the front end. So, in some sense, this is what happens when you come in late, right? At any rate, 24% in hospitals 1 and 2, very similar to these numbers, got it in the ICU. And actually, there were more patients who got continued screenings after they got after they got discharged from the ICU and they were finally on the ward. Interestingly enough, more than half got screened in the ICU in Hospital 3, and they had just about the same percentage going on when they were in the wards. So virtually nothing different across these 3 hospitals when you're considering the ward, but wildly different when we're talking about the ICU. Now, when you compare those in the ICU compared with any assessment, what we find out is that these 59 are 75% of all of the screenings that are accounted for here as any assessment took place in the ICU. Now, this 44 is 56% of this 79 figure. So what we can see here is that there's a lot more people who got assessed on the ward. And again, there's duplicate data here, who got assessed on the ward when compared with the ICU. So what in the world is going on here? We found these as the predictors. This is nothing new. Most of you have probably heard this before. Females likely because they might have had ET tubes that were larger. Duration of intubations were a predictor for whether patients got a swallow screen. And certainly we know that there's a hospital difference here, and you can see that. And I'm sure you'll see that across different facilities that you're familiar with. Nothing unfamiliar, nothing surprising here. Now let's take a look at the methods. If you go through an article and you spend some time in the methods, the really good, juicy details are there. Spend the time there because what you're going to realize is that there was a nice little explanation. And behind the scenes, after we crunched these numbers, I personally went back to hospital number 3 and I said, "What's up? What's going on here? I don't understand why you guys are double us." Here's the reason. Hospital 3 was the only site with an ICU-based nurse-administered swallowing assessment algorithm that could prompt physicians for SLP referrals. In other words, the first 2 hospitals never had anything. We are going back old school. Remember, this article was 2014 and much preceded a great number of the studies that have come out since then. In fact, most studies have come out since then. There weren't so many studies before then. What happened here is that they were actually using the Massey screening. Now, if you recall, the Massey screening was completed maybe about 7 or 8 years earlier, never took a look at the ICU, and only took a look at 25 patients. But this is what that hospital chose to use because their main patients were stroke-based, neurologically based, and they felt that that was appropriate. This is not a criticism about what they chose as a screening. In fact, kudos to them for having a screening at all, and certainly in 2014. The point here is that this is information I found out after we collected the data, after I was involved. So my point here is we need to continue to question, we need to continue to dig because the answers may not necessarily be in front of you as you're doing the research. That was the surprise to me. And what I've taken from that is to ask really good questions as I'm moving forward in the research. Again, surprises may come, and you need to be able to pivot relative. But this was something that nobody was expecting, and only I was the one who went back saying, "What in the world?" And I went back to the original source to figure that out. All right, let's pivot a minute, and we'll come back to these systematic reviews. I want to quickly go through these because that is not the point of this presentation. We all know that laryngeal injury happens to patients who are extubated. We also know that ICU is a little bit more severe than those who are surgery patients. We know that, thankfully, um, greater injury or more severe injury is actually less as we go further in the amount of time, let me restate that. Patients are more severe in longer durations of intubation, but thankfully, patients are actually having less intubation in the first place, and many of them can walk away without a problem in the first place. Okay. We know that intubation duration matters. We know that hoarseness, certainly from this study, certainly from previous literature, is not a sufficient screening tool. Dysphonia is not necessarily related to dysphagia, although they can co-occur. There's no guidelines for assessment, and there's no conclusions at the time of this study that can directly link the size of the endotracheal tube or the endotracheal tube materials to laryngeal injury. Now, moving forward from this systematic review, that systematic reviews, two of them that were done in 2018 and 21, we know that the studies that were done by Mark Moss and his crew in Colorado, in conjunction with Susan Langmore and Emily Plowman's work in 21, have shown direct links between the size of the endotracheal tube and laryngeal injury. Okay, and by the way, aspiration as well. But that's not the point to this. That was the background. Some of the chaos we need to deal with in the critical care literature, they're a little bit more, shall we say, mm, willing to come forward in an editorial that is published adjacent to your study. We got these comments. The data notwithstanding, the question remains, are the injuries long-lasting, or are these injuries better viewed as trivial and transient collateral damage from an indispensable procedure, effectively saying, what's real? Or you might be able to read that as, well, we've never cared about it before and it's never really mattered before. Should we care about it now? Good question. I don't have that answer yet, but I'm going to say yes. Second question, how can we minimize the adverse impact of endotracheal intubation for future patients? Aside from the reference to the guideline on hoarseness, the systematic review is silent. Want to know why? That wasn't the point to the systematic review. A detailed post-extubation upper airway workup is unlikely to occur for every patient. And to that I say, hogwash. Why couldn't we? Why shouldn't we? Right? Were it not for the resources, and I'm talking everything from endoscopes to personnel, we would be able to do that. With sufficient resources, we would be able to understand what's going on. Okay? So if we had the resources, why wouldn't we work toward that end? And I'll just give you a hint. There's more information coming out on the heels of the R01 we just completed. Stay tuned. Finally, the last question. There is indeed a price to be paid by the patient for the chance of undergoing endotracheal intubation and mechanical ventilation. The search for ways to minimize apparently obligatory accompanying injury must continue. So effectively, they've gone from this question up here saying, should we even care, to, yeah, let's figure this out and let's see what we can do. So then the question is, what now? What next? Right? So part of the chaos that I'm trying to get at is there's an ongoing dialogue here. These questions, although you may read the article, and certainly as an author, you may read your own article and say, boy, are they just being critical? I can't believe this, and take it in a personal way, right? The reality here is this is what pushes research. And the way we took this was, maybe we can do better in the next study. Maybe we can find out some of these questions. Okay. So that's how I personally, and I think many people, approach research. It's not just learning from the stuff that you did, it's learning from the comments in the reviews that you get from the reviewers on your articles. It's editorials that are written directly focusing on you and saying, what can you do better? You're the one in this space. You're the one researching it. These are our thoughts. Effectively, this becomes a group project, right? Okay. This was a little bit of a heads up. This article, the top article over here, was the one that we wrote. The ones followed up very similarly in a very similar time frame was done in Europe. And all of us talking about this multidisciplinary thing we call dysphagia in the ICU. That aside, this was the table. These are the data that we presented in this article. And for those of you who have heard me speak before, I've presented this information this way before. identifying the SLPs, where we are relative to all of the other disciplines, and how frequently we are involved with dysphagia, which is no surprise, by the way. But it's also these other disciplines as well: critical care, ENT, nurse practitioners, physical medicine, nurses, GI, OT, neurology, physical therapy, psychology or neuropsychology, and radiology, right? The obvious players with dysphagia. And we pointed out that neuro was in two of these. Now, I want to draw your attention here because this is the way, right here, right now, this screen is the way that I presented it previously. And it was because of the cranial nerve exam, okay? But I have to say, and taking a pointer at me or pointing at myself and saying, look, I wasn't looking at this with quite the right perspective. Because when you think about where else neuro could be in the things that they were doing, they have a lot greater responsibility in the ICU. So the lesson that I took from this was I was looking at this monocularly, and you can see the difference between the black writing in this column right here and the red neuro that I've added in these spaces here, where they really should have been involved, where I should have stated this is what was actually happening, where they do have a role, and a little bit short-sighted and a little bit binocular on our part in this regard. So again, nobody is safe from criticism. And it was only after years, this article came out in 2020. I realized this several years later and said, I just wasn't looking at it right. So even being critical to yourself is another lesson that I've learned behind the scenes. Now, I want to move into the PALS grant that I was telling you about. Many of you may have seen this post on social media. This is the grant that we got back in, I think it was 2014. Um, Maybe it was a little bit longer than that, 2016, maybe. Um, and these are my co investigators, Vincia Pandian, who is a PhD nurse. She was at Hopkins and is now at Penn State right now as an associate dean. And then Dale Needham, who is an intensivist in the medical ICU at Hopkins. Fantastic folks that I have worked with. This is the PAL study. This is the thing I've been waiting for now 7 years to be able to share with everybody, and you're going to get a highlight right here. So it's the post-extubation assessment of laryngeal symptoms and severity. That's what PALS stands for, and you're going to be hearing much more coming from this study in the upcoming months and years as we analyze the data. This article came out just in January this year, and this I want to make the focus of the information. All right. Interestingly enough, only those folks who are highlighted in blue right now actually still remain at Hopkins. Everybody else, including myself, has moved on to another institution. So, one of the things that we need to realize here in research and in life in general is that people move around. And one of the challenging things that many of us face is keeping track of our colleagues, making sure we're updated on emails, and certainly the emails and the communications that go back and forth trying to get literature submitted or manuscripts submitted and abstracts submitted. The objectives of this particular research, and I want to focus here, they were research based, was to determine the challenges and the facilitators of doing flexible nasal laryngoscopy in the ICU. Now, everybody on this call should be able to immediately move into a clinical space saying, well, how does this affect me? I'll get to that in a little bit. But I want to seat this primarily in the research realm because we were following a research protocol, not a clinical protocol, in order to make this research happen. and there are very big distinctions between them. The secondary analysis presented in this research is whether we could do the Yale Swallow protocol while we're doing the flexible nasal laryngoscopy. I'm just going to say FNL from right now. All right. Here's the study design. We took a look. This was all prospective. Single academic medical center. It was at Hopkins. We were in 6 ICUs and we enrolled 107 patients. Now, let me stop right there for just a moment. That looks pretty mainstream. You'll come across wording similar to this in many, many studies across the world. But I want to parse this a little bit. Our team was a really special team in that we did this 7 days a week, nearly 365 days a year for the full, I think it was 5.5 years that we were collecting data. This was very specifically almost a non-ending protocol. And when I tell you nights, weekends, this was for all of the postdocs I was working with. This was for Vincia and me doing scopes on the weekends and in the evenings. This was a very concerted effort on everybody's part, and I can't possibly underscore the thanks for everybody's efforts along those lines. All right, so inclusion criteria adults who were orally intubated. They had at least 8 hours in the ICU, according to the team, and intubation duration during that period of time. Exclusion criteria, broadly speaking, you can read for yourself. Broadly speaking, what we were looking to do is isolate anything that might be related to a voice or swallowing disorder, get that out of the mix, and get it only those patients who never had a problem in the first place and are only going to be evaluated following the course of their disease or their illness as a brand new individual to whatever critical care treatment they went through. This is the key piece to the paper. If you spend no other time on this paper, if you're able to download it, this is the key table right here on what we did and why we did it. Okay. What I want to do, however, is draw your attention down to these 3 things right here, the IRB procedures. Here's the challenge. Before we even got to the IRB, we needed to go to the medical director of the medical ICU and ask his permission to do research in the ICU. That was not an IRB thing. That was an ICU thing. But it was also an IRB thing that they requested. We just happened to have it in our back pocket when they asked for it. So, having had the experience on prior studies and needing to go to that director, we did it again ahead of the IRB and we submitted that his approval in a formal letter to the IRB saying we could be in his ICU. Issue number 1. Issue number 2, we had a 3-gate procedure to even get to the patient. Not many institutions deal with this. It was an extra level onto that. Level number 1 was screening in every way that you think it is. Level number 2 was going to the attending and asking their permission once we got and found out that a patient was appropriate. Level number 3 was having somebody unrelated to the research, meaning not one of my team, not one of our team, somebody who actually works in the ICU, whether it was an attending, a fellow, a resident, or an APP, somebody needed to go into that room to speak with either the patient, the proxy, the legally authorized representative, there's another term for you, to get their permission for us to approach the patient or themselves. That is a key step because that was a barrier during this research. As you might imagine, people are not going to explain the research in quite the same way as you would as the investigator. And unfortunately, we had many denials. We'll come to that in a little bit. So that was a three-gate procedure. The fourth gate was actually the consent from the patient or their proxy. So these were the things, the hoops, if you will, that we ran through. We had to do this. This was the institutional review board that said we needed to, and that's outlined all right here. Okay. And as you can see, we go on into further study procedures. So there's a lot of steps here, a lot of things that were done here. I'm just highlighting the big things that really impacted the study. Okay. 4 steps to the research: screening, the medical assessment of the patient done by all of the postdocs. And by postdocs, I mean MD postdocs, not PhDs. The FNL procedure and the Yale Swallow protocol. Those were the steps in this broad study. What we came out of it with was most people were about 60 years of age. Almost half were female. Their BMIs were a little bit elevated, but not terribly. Ventilation duration actually was about 3 days. So it differs a little bit than the previous study, right? We got a different patient mix. But when you see 75% of them have 1 day to 6 days of oral intubation, you know that we got a pretty good range. Their length of stay in the ICU was 7 days, and their Apache score left them with a 22, which was pretty moderately impaired. Um, This was the distribution for race, nothing different than what you would recognize in the city and surrounding areas of Baltimore. This is another highlight. These were the barriers to being actually able to get the data. Patient death, you can see, occurred in 8 patients. That's nearly taking into consideration all of these were all of the patients that were excluded due to problems. So we've got 8, another 14 is 22, plus another 3 here is 25 patients of the 107 that we had originally. Okay, so it's about 25% of our patients who actually came into the study. These were the ends of our ability to collect the data, and you can see death exceeded everything else. The key challenges, as you might have expected, mortality and clinical deterioration that are, of course, not modifiable by us. These are things that we're stuck with, and that's the end of it. Just got to deal with it. Equipment availability and functionality, and we've all experienced these kinds of things. Scopes that have broken or have leaked, the computer's not available, all the things that everybody deals with clinically, we also deal with in research, and effectively it can bring your study to a grinding halt once those things are in disrepair in order to get them to repair. Patient agitation and refusal affected protocol adherence as well. Those patients who refused or were agitated were removed from the protocol. We couldn't go any further simply because they weren't appropriate to participate. And then finally, the gleaming light here is that when we had assistants with speech language pathologists who were simultaneously consulted with us, they actually helped us get consent. They were actually able to calm the patient down. They were actually willing to help us with a second set of hands to be able to get the information that we needed to collect for the research. So that was the one bright light in all of this. Clinical implications, finally, right, to all you clinicians out there, this research has definitely shown that flexible nasal laryngoscopy is feasible in the ICU and even under research conditions. We had a 75% success rate in being able to do this. Now, for all of those folks out there who are having difficulties in the ICU and difficulties getting flexible endoscopy to the ICU, here's yet another paper that demonstrates this is feasible. And it's one more thing to have a discussion with your directors and with your supervisors and the members of the ICU core team. It is a well-tolerated procedure. Not one patient on this protocol from beginning to end. You only saw 107 here, or about 80 who were intubated, and we got the data. The full protocol had 560 plus patients on it. Not one of them were given a drop of medication. Nothing. Every single one of these patients we scoped without medication, and you can see on a 10-point scale, the median was 2. This was well tolerated by every single patient. Jonathan Aviv's paper underscores these same findings, or more to the point, I guess we underscore his findings. He had 1,000 patients coming into his study. Early assessment is achievable. Most of these patients were scoped within 10 hours post-extubation, which effectively means that they were extubated in the morning. We got to see them later that day, or at worst, the following day. So this paper right here, I think will go a long way in helping every single one of you who don't already have fees in the ICU to have that discussion with the ICU directors and everybody else who's associated with that. The clinical implications here, we know that we can do an enhanced clinical assessment. We know that we can get early detection of these issues to find out what's going on and to treat it sooner than what we normally would have been doing that. And in fact, that occurred in about 11% of our patients. And then finally, it only underscores the multidisciplinary care that these patients get, especially with the Yale Swallow protocol and its ability to detect problems with aspiration. I want to leave you with a first thought of one of the two thoughts that I have, that I've others have seen me or heard me speak about this. In seeking absolute truth, we aim at the unattainable and must be content with broken portions. That is a clinical phenomenon. That is a research phenomenon. You will never have all of the information that you need or want, but you'll have enough information to be able to move the ball forward. Rest on that alone. And then finally, this is where I've been. I've learned a great deal as to what has been going on in the ICU over these 2 decades. And now that will set me up, and hopefully others may learn from this for future in the things that we do clinically and in research. I'm going to leave you with this screen for a moment and let everybody know that this conference is going on in September. Aspire is going to be supporting this conference, so a big shout out and a giant thank you to them for not just allowing me to speak tonight, but to also for their support at this conference that we're looking to get everybody talking about voice, swallowing, and upper airway disorders. Grab your phones, grab the QR codes, register for the conference, reserve your rooms at the Marriott. And if you have any questions, by all means, feel free and contact me. I'll be happy to discuss that with anybody. And with that, I say thank you for giving me the opportunity to talk with you tonight. And if we have some time, I'm happy to answer any questions.
Thank you so much, Dr. Brodsky. That was incredibly insightful, and thank you for doing this work because it sure does not seem easy. It is definitely essential for the rest of us to be able to best care for these patients. So
Absolutely.
appreciated. We have just a couple of questions. I know we are short on time, so I'll try to get through them. Our first question is, how did you navigate FNL with patients on high flow nasal cannula? Was this possible in your study, or did you have to wait until weaned?
That was a patient by patient perspective. That patient by patient perspective was a rich discussion with the ICU team, but high flow nasal cannula as a device was never a barrier for us. The barrier was the patient's prognosis. Patients, as many of you know, anybody on high flow nasal cannula, CPAP, BiPAP, whatever it may be, after they've been extubated, they're about that close to getting reintubated, or they're going to make it beyond that and they're going to fly. That's the question. A nasal endoscope can bypass the high flow nasal cannula. And even in times as rich as these discussions were, patients on BiPAP, for example, we had the discussion with the respiratory therapist saying, do you think we could move them to a high flow or a nasal cannula? And a good percentage of the time, the answer is yes. They just hadn't gotten around to it yet. So it is worth the discussion. You should always have that discussion. Don't go in blindly. Go in with as much knowledge as you can to make that clinical decision.
Absolutely. A discussion is always valuable.
Yeah,
We have some facilities have guidelines to wait 24 hours post-extubation for a swallowing assessment. Does this research suggest this timeline should be reconsidered?
absolutely 1,000% it does. You saw 10 hours there. And what was the range? The interquartile range. I don't think I actually put that in the slide, but now that I'm thinking about it, I'll go back and take a look. Let's see. So I don't think I have those data with me. They may be in the article, and I'm pretty certain they're in the article. But I can tell you, we were scoping patients well within 1 hour of extubation. I've been doing this most of my career. So no, hands down, absolutely not. There is no such thing as a 24-hour rule. It was never a thing. It will never be a thing. Do it when the patient is ready. You need to use your clinical judgment on that. Can they respond to you? Are they still drowsy? Are they appropriate? And the bottom line is, if it were your mother sitting there, would you want to give her the water or not?
Absolutely. Yeah, everybody is
Finger
going
in
to
the wind.
be reading this article. Okay. And would all of this still relate to patients who were intubated and then switched to tracheostomy?
None of the patients, let me say this. Any patient who was switched to tracheostomy was out of our study unless we could get a nasal laryngoscopy within that window that they were going to move the patient to the tracheostomy and within 24 hours of it. I believe that was the protocol, and that was rare, phenomenally rare.
And our final question, well, it's a thank you. And do you have an email contact where people can contact you?
I
Um,
absolutely do.
that you
And let
share?
me I'll put that in the chat. How's that?
Sure. And I'm also going to share my email. If anybody wants to request a certificate of attendance for PDH, you can feel free to email me. Or if you have any other questions, feel free to reach out. And Dr. Brodsky, we will conclude here. Thank you so much. We appreciate you very, very much.
I
And thank you for the
appreciate that,
audience.
Jenny.
Have a good evening.
Thank you. You too. Take care, everybody.
Bye.
Bye bye.